let's have a think about some genes. So here's some DNA. Let's have a think. Now, if you want to go and entertain yourself and learn about the breast cancer genes, go and see this film, Decoding Anna Parker, with Samantha Morton, Helen Hunt, and Aaron Paul for the ladies. And I've seen it's actually quite good. It talks about how the BRCA1 breast cancer gene was discovered and how nobody believed that it actually ran in families genetically and how it was all done. So if you want to, go and watch that, and it's quite a good watch. So when we talk about breast cancers, about 85% of what we call sporadic, they just happen. There are no known reasons, no connections, nothing. It just happens out of the blue. Okay. Around 10% of them are what we call familial. They run in families, but without any known genes. So these are the things we talked about. Well, there's something in the environment or something in the diet that because you've grown up in the same place, your risk is slightly higher. So these are the familial ones, and the last little group are the hereditary ones. These are the ones that particularly run in families because of abnormal genes. Now we've got about 5% there, it's probably only about 2%, it's slightly less common than we thought, but these are the ones where you can identify an abnormality in the genes that's passed on through the family rather than just something in the environment. Now there are two indications where you might be suitable for genetic testing to see if you carry an abnormal gene. The first one is if you develop cancer. So if you develop ovarian cancer now, you should be offered a gene test for the BRCA1 or 2 genes. If you get breast cancer at a young age, now this is where things differ. In the NHS where I work, we'll only do it, or the NHS will only do it if you're younger than 30. I think that's too young, and probably it should be under 45. So if you develop breast cancer under 45, you should probably be offered a gene test, but you may not get that on the NHS. The trouble is, the criteria will differ around the country depending on the resources available. Similarly, if you get breast cancer in both breasts, one after the other, and one happens at say 40 and one happens at 50, so both of them happen before you're 60, again, you should be offered a genetic test. I'm going to talk about this thing called triple negative breast cancer in a minute. Any man who gets breast cancer should get a genetic test because obviously it's much less common. And if you have a first-degree relative, so you see that's a parent, a sister or brother or a child with any of the things we've talked about above, then again, whatever your age, you should be offered a genetic test if you develop cancer. Now the other group is those of you who haven't had breast cancer but have a family history of breast cancer. Now again, this is where it gets more complicated, and we have to keep referring to what first and second degree relatives are. And again, it may differ around the country because of resources available. Okay. But if, for example, your mother developed breast cancer under 40, or you had a sister who develops breast cancer under 40, or we occasionally see the mother of a patient who develops breast cancer under 40, so their daughter, we do occasionally see that, then that would be an indication for talking about genetic testing. If any first-degree male relative, so father, brother, son, develops breast cancer, you should have the test. And then again, a bit like the bilateral breast cancer under 60, if you have a first-degree relative, and again, there we are, it's parent, sibling, or child, bilateral breast cancer under 60, be referred for genetic test. And then we get a bit more complicated, because if you have 2 first or second degree, so for example, 1 first or second or 2 second degree with breast or ovarian cancer at any age, get tested. 3 first or secondary relatives, breast cancer at any age. And then we're always taught that the Ashkenazi Jewish population have a high incidence, but probably it's any Jewish population, or probably now any Polish ancestry as well, would be enough to make you consider genetic testing. I'm sorry, that's a bit complicated. It does go on a bit, but those are the sort of criteria that we use. And these days, and again, complicated slide, we don't just test for the BRCA and BRCA2 genes, which you see in the top left-hand corner. You can now test for a whole panel of genes, not just related to breast cancer. And if you like, the BRCA1, excuse me, and 2, and a bit further down, what we call the TP53 and the P10, you might call those the major breast cancer-related genes, and all the others are minor breast cancer-related genes. So we can test for all of these, but also ovarian cancer, colorectal, uterine cancer, melanoma, pancreatic cancer, gastric cancer, prostate cancers, and other cancers. You can have these panel gene tests that will test for all of these. And testing all these probably is about £500 now. And this is where James Mackay, our consultant genetic oncologist, would come in, where he was top left on the photograph for part of our team members. What he would do, he will see you, he will go through your family history, he will talk about the likelihood of finding an abnormal gene, because he's not going to recommend you have a test if it's not really going to tell us anything. And the other thing he'll talk about is what you do about an abnormal test should you get one. So the test itself, probably about £500 now. You'll still find the NHS sometimes they just test the BRCA 1 and 2, but actually doing these panel tests really isn't much more expensive anymore, and it gives you a whole lot more information. But you have to think about how you manage it. And you get 3 possible results. And if I just talk about the BRCA test, most ladies, I'm pleased to say, all their genes will turn out to be normal. So what that means is you're not at increased risk of breast cancer. That's sort of good news. Or you get what we call a pathogenic mutation. So this is one of the mutations we know about, so a change in the gene. And remember, a gene is a whole sequence of these bases in the DNA. It's like letters in a book, and if some of them are misspelt, and we know this causes breast cancer, this is what's called a pathogenic mutation. This means your risk of breast cancer is increased significantly. And it's probably up to between 60 and 80%. And I'll come back to that in a minute. But the important word there is up to. Sometimes you get a change in the letters of your gene, and it's not something that we know is related to breast cancer, but we call this a variant of unknown significance. And what the big companies will do, so for example, Myriad, who's done most of the world's genetic testing, they will register this and keep an eye on it. And if in 5, 10, 20 years' time, this becomes a gene that they recognize is related to cancer, they would contact you and tell you. So if you have one of these, it's not related to breast cancer, your risk is not increased as we know, but if over time things change, they will keep a record and get in touch with you as somebody who had a variation of unknown significance that now becomes significant. That's really quite important, that a record of these things is kept. But at the moment, variations of unknown significance are not known to increase your breast cancer risk. So what do you do with an abnormal result if you have a pathogenic mutation, as we call it? So on the left, obviously, Angelina Jolie, who had breast and ovarian cancer in her family, was found to have a BRCA mutation. She had a bilateral mastectomy and a reconstruction. And what you will have read in the papers that Angelina Jolie's risk of breast cancer was, I think the figure was, they said she had an 87% chance of getting it. And that's not right. Her risk was up to 87%. Now, the trouble is, yes, these mutations increase your risk, but that's not all there is to it. And other things have to happen as well that we still don't quite understand. So the risk was up to 87%. It might have been 10%. It might have been 20%. We don't actually know, but it was up to 87%. So when you have a pathogenic mutation, your risk is up to a certain level, but we can never give you an exact figure. So one option is you have what we call a risk-reducing mastectomy. You have the breast removed and a reconstruction. And we deliberately call it a risk-reducing mastectomy because it doesn't reduce your risk to 0, but by removing most of the breast tissue, it reduces the risk. I have seen ladies who have had bilateral mastectomy implants who will get breast cancer, because the difficulty is you can leave occasional breast cells behind when you do a mastectomy, and they can become cancerous, but the risk is significantly reduced. The other option, and on the right, is a digital mammogram machine. We have a three-dimensional digital machine here, which gives us very clear pictures. You can go into what we call enhanced screening. And what we would do, if you have a BRCA1 or BRCA2 mutation, between 20 and 29, when breast cancer is still very uncommon, very important that ladies keep an eye on themselves. And actually, for any lady any age, if you're checking yourself and something's new, different, or a bit odd, actually you get it checked. And again, I'm delighted that most ladies I see are fine, but now and again you'll pick something up. So new, different, bit odd, get it checked, whatever age you are. But even with one of these mutations, we don't need to do anything apart from make sure ladies keep an eye on themselves until they reach 30, and then we start screening with MRI scans. And the reason we start with MRI scans is when you're young, the breast tissue is very dense, and as you remember, mammograms are deliberately very low dose X-rays that do not go through dense breast tissue particularly well. So yearly MRIs is what we would do. Once you get to 40 and the breast tissue begins to get less dense, you will have MRI scans and mammograms, because international trials involving thousands of ladies have shown that the two together is better than one on their own. Once you get past 15, past the menopause, and the breast tissue is much less dense, mammograms on their own, and it should be digital mammograms with tomosynthesis like we have here, they're okay on their own. If you have a digital mammogram and one of our radiologists looks at it and says, oh, I'm not quite sure that that's clear enough, then you would have an MRI scan as well, but not automatically. So you can either go the Angelina Jolie route, or you can go on the screening high-risk groups, and we have ladies who do both. Most ladies in the high-risk screening, nothing happens, but sometimes it does. And some ladies, if they've been screened for 5 years, will decide, actually, I don't like this anymore, I'm going to go the Angelina Jolie route, and that's also absolutely fine. So those are your two options. But as I say, you now get a panel gene test that covers all sorts of genes, not just related to breast cancer.